So these are the mode of action. So these are the mode of action. Then, then what are the brands available in the market? You already know. I already told you that only serotype A is only available in India, not serotype B or C or D. So this is the botulinum toxin or botox. You have seen already. This is Ona botulinum toxin A. So this is a botulinum toxin serotype A, but they have given the name of Ona botulinum toxin A. Different brands, they used to have a different name for that one. Then second one is the uh, incobotulinum toxin, that is geomine. The botox was the first botulinum toxin drug to be registered in 1989, followed by Dysport, followed by Neuroblock or Myoblock, and followed by geomine. So botox is the first drug to be registered and followed by Dysport and Neuroblock or Myoblock. The Neuroblock or Myoblock is the botulinum toxin type B. So that is available in the liquid formulation. That is not available in India. Then geomine in latest in 2005, and subsequently also there are some Indian manufactured brands are also available in the market like Jarbot. Am I audible?
Recording in progress.
Ashwini, am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Okay, some network issue happened because the electricity went away, so that's why.
Yes,
Slides are
audible, sir.
So this is the monobotulinum toxin type A, which is Botox. Then the incobotulinum toxin A. These are the botulinum toxin type A, but different manufacturers have different names. So Geomine is the incobotulinum toxin A. Then Dysport is the abobotulinum toxin A. These are the international brands which are available in the market. Then currently we have a Indian manufactured brand Jarbot. So all are botulinum toxin type A only. But depending on the what type of preservatives or what type formulas they are using, the name is to differ. And this Botox and all, ornamental toxin is commonly that is the first one to be registered. So that is the standard brand they used to keep to compare all other botulinum toxin preparation. The Neuroblock or MyBlock is the liquid formulation which is not available in India. So that is the only liquid formulation. Rest other are the powder formulation. So what is biological activity? So when speaking about like botulinum toxin 100 unit or 15 unit, what do you mean by unit? So that is called biological activity. So it is a therapeutic BT preparation is given in form of mouse unit. So these mouse units otherwise called as units. So what do you mean by mouse unit? The one mouse unit describes the amount of botulinum toxin which would kill 50% of BT insects of mouse population. And one mouse unit of Botox is equivalent to 3 mouse unit of Dysport. So if Dysport you are using, that is the dose is usually 1/3 or the 3 times of that of Botox dose you have to use. And Botox, Geomine, and Jarbot used to have a similar efficacious or same type of MU unit are the similar. So these are the different formulation of botulinum toxin. You can see the stabilization by vacuum drying. Dysport is the freeze drying. So if you are using Dysport comes in form of lyophilized formulation. Geomine also comes in the vacuum drying preparation. So this vacuum drying sometimes that film is not visible in the botulinum toxin vial. So sometimes it is seen, and whatever is seen that is the impurities only. Because if it is purely only botulinum toxin, it will not be visible in the naked eye. But if it is vacuum dried, then once putting the syringe inside, then that will suck the saline into the bottle. That is the proof that the vial is not used previously. And this biological activity you can see in the slide. The Dysport is 1/3 of that of botulinum toxin, and Geomine and Jarbot are usually equivalent in the mouse unit biological activity. So all botulinum A drugs are to be reconsidered with 0.9% normal saline prior to application. Only NeuroBlock or MyBlock, which is type B, is ready to use solution formulation. And Geomin and Jarbot is the only drug which can be stored at room temperature. And another Geomin usually have a shelf life, usually very long shelf life because it has have lack of any complex in protein. So sometimes Geomin, if you ask after reconstitution of botulinum toxin or like in brand of Botox, if you are using Botox, then after reconstitution you have to use within 4 to 5 hours only. According to the monogram given by the company itself, so you have to use within 4 hours. After that, there is an efficacy of using that one is not good. It can be discarded after 4 hours. But for Geomi, it is stabilized, so you can use up to 8 to 10 hours also. And recently launched this Jarbot, they are claiming that you can, after reconstitution, you can use up to 24 hours also. If one person is taking 100 unit and 20 units is left out, you can keep the 20 in the freeze and you can use after within 24 hours also. So that is the advantage of newer formulation of botulinum toxin. Coming to spasticity proper, what the definition of spasticity by Lance? It is a motor disorder characterized by velocity-dependent increase in tonic stress reflexes with exaggerated tendon reflexes resulting from hyperexcitability of the stress reflex. This is the classical definition of spasticity. So the epidemiology of post-spasticity usually prevalence is 19% to 92% of in different studies. And its prevalence may as high as 38% in the first year following stroke, so which is very significant in the first year itself. So for that reason, we used to counsel all the stroke survivors to start the rehabilitation or physiotherapy as soon as possible. So if you're in the first year not taking care of the limbs, then that may lead to contraction in the future part of the life. So this is the mass scale used to score the grade of spasticity 0, 1, 1 plus to grade 4. So these are the for objective assessment, how much spasticity there, whether the patient need any botulinum toxin or if a patient has taken already botulinum toxin, whether there any effectiveness is there or not there. Come to the different patterns of upper limb spasticity. You can see in the video. The video visible?
Yes, sir.
So you can see this is a classical hemiplegic gait. The arm in the flexion position with the fingers in the flexion position. The leg is in extended position with there is some curling of toes on the left side. So this is a classical hemiplegic gait. So if you see in the upper limb spasticity, there are different forms are there, different patterns of upper limb spasticity there. The first one is the adducted internal rotated shoulder, as seen in the video. And second one, the flexed elbow, then a pronated forearm, then flexed wrist, then extended wrist, then clenched fist, thumb in palm, adducted thumb, interchanging plus hand, and extended wrist. We'll discuss regarding all these patterns of upper limb spasticity. Then coming to the first one, adducted or internal rotated shoulder. The muscles commonly involved in the adduction or internal rotation of shoulder are the pectoralis major, which is the strongest muscle for this pattern of upper limb spasticity, followed by some due to teres major and latissimus dorsi. Okay, you can see in the photo, you know, all these muscles, pectoralis, teres major, and latissimus dorsi, but how to approach and how to inject. The pectoralis major, it has three attachments: clavicular attachment, sternocostal attachment, and abdominal attachment. You can see in the axillary fold you can use. So in the axillary fold, you can hold the pectoralis major muscle and you can inject directly. And you have to give at least 100 units. Sometimes, according to the patient's affordability, you can use 50 to 100 units. And also depend on the grade of spasticity. If spasticity is very minimal, only grade 1 to 2, then you can use also low dose. If severe spasticity with contraction, then you can give a higher dose of botulinum toxin in the pectoralis major with the simplest muscle to be given in post-spasticity. The second muscle, teres major, it has to be given from the backside. And you know what is the origin and insertion of teres major. It starts from the humerus and inserted in the medial border of the inferior angle of the scapula. And function is the adduction, internal rotation, and extension of the shoulder. Injection from, you have to give it from the lateral part of the scapula from the behind, and you can target the infra-angle of scapula. Where is the infra-angle of the scapula? You can go 3 to 5 centimeter superior to the infra-angle of the scapula, and that is the site for injection of teres major. Can you follow?
Yes, sir.
Yes, sir.
So this is the landmark. You can scapula. You have to go 3 to 5 centimeter. Classically, you can put 3 to 4 finger braid, go up, and you can give injection here, like in the picture. And dose is 15 minutes at 1 to 2 sites. In the latissimus dorsi, so this teres major is slightly up the inferior angle of the scapula, and latissimus dorsi is just below the inferior angle of the scapula. So this is the latissimus dorsi you can see. So this is the inferior angle of the scapula, and just below is the injection site. And you can, while injecting, you can do the activation procedure to see the contraction of the muscle. So there are different methods of giving injection of the muscle also are there. Like if you can use finger to palpate the activity of the muscle. Second, you can use EMG guidance. With a EMG guidance, you can give to the accurate muscle. Sometimes also you can give use the ultrasonography to localize the muscle. And it is the best to use ultrasonography along with EMG guidance to properly localize the muscle to be injected. So for the latissimus dorsi, the prominent muscle just below the angular muscle is the latissimus dorsi muscle, or in the area of posterior axial line, 7 to 8 centimeters below the axial fold. So these are, you have to remember, like anatomical landmark you can do. If you don't have needle EMG or EMG guidance is not available because it's the costly one, EMG guidance, almost 2,500 to 5,000 they are charging. And it is single use means patient can use 2 to 3 times, but again, it is a costly one, so that's why it is not available always. So if it is not available, then you can use your guidance or finger EMG used to call it. So you can palpate the muscle, see the activation, and you can do the injection. Come to the flexed elbow. So these are the flexor muscles: brachioradialis, biceps, and brachialis. So brachioradialis, you all know that brachioradialis is present in the just above the, just below the elbow crease. So this is the point between the lateral epicondyle and bicep tendon. So in between the middle point of the biceps tendon and lateral epicondyle, you have to inject. So this is superficial muscle. No need to have any difficulty for the brachioradialis muscle. And you can use the dose of 25 to 50 units of botulinum toxin type A. Okay.
Yes.
Yes.
Then come to the biceps, the biggest muscle. There will be no difficulty in identifying the muscle, but there are different techniques of injecting the biceps muscle. In the picture, you can see the person is injecting from the lateral border. The pointing end is from the lateral, vertical to the muscle, or again to the lateral end. So now they are telling that if you are giving through the lateral approach, then the muscle is better targeted, and injection is to the botulinum toxin is to keep in the that biceps muscle. Chances are more of injection in this procedure than the direct vertical injection technique. And dose is 80 units, but we sometimes use 25 to 50 units also, depending on the availability of the botulinum toxin. Then and this is the easier one, but difficult part, the brachialis part, because brachialis usually lies just beneath the biceps brachii muscle and is the strongest flexor of the elbow muscle. So because it is very present deep to the biceps muscle, so erroneous injection in the bicep brachii is usually common in this process. So for that reason, you have to push the biceps to medially and then injects just below the biceps muscle. Or you can take a EMG guidance. So at level of 4 finger breadth above the lateral epicondyle, if here is the lateral epicondyle, you can put a 4 finger breadth and you push the biceps medially, and from lateral approach, you can give just below the biceps muscle and above the humerus muscle. And injection dose is 15 unit. Also, you can use more if patient have more severe flexion contracture of the elbow region. And then coming the pronator arm, pronator forearm. the two muscles are involved in this frontal teres and frontal quadratus. So you can see this is the posture of pronated arm. So for frontal teres, the landmark is, so this is the biceps tendon. Is the marker visible?
Yes, sir.
Is the marker visible?
Yes, sir.
So
Yes,
this
sir.
is the biceps. So this is the biceps tendon. This is the medial epicondyle. So you have to put two finger breadth distal to the line joining the biceps tendon and medial epicondyle, and the midpoint is the point for injection of botulinum toxin. You can see the cross mark is there. This is the point for injection technique. So here like this also you can see. So this is the point. The two finger breadth distal to the midpoint of line joining medial epicondyle and biceps tendon. Dose is 25 to 50. You can see in the video. Here I've injected. Are you seeing this needle?
Yes, sir.
So this is needle, and before injecting for the deep muscles, the last time what we have used for hemifacial spasm is the small needle. But here I have used a long needle. This is called 2.5 inch needle. 26 gauge, 2.5 inch. This is a long needle. So that is not always available in the market. So you can ask if you're giving deep muscles like this one, then you need to have it long muscle. That will be helpful for proper targeting the deeper muscles. Okay. So this is 2.5 inch needle, long needle. Correct? And you can also, this one I am doing without EMG guidance. So I am using the activation process to properly localize the frontal teres muscle. Great. Then other muscle is the frontal quadratus. You can see in the picture, frontal quadratus is just present, proximal to the wrist crease. So you can inject it from the dorsal aspect or hand in the pronation position, 3 finger breadth distal to the wrist crease, and between the radius and ulna you can put the injection needle. So you can give frontal quadratus if patient have a severe pronation of the forearm, particularly in the distal part if it is there. If it is in the proximal part, you can give more to the frontal teres part. From the flexed wrist, so flexed wrist, the muscles involved are flexor carpi ulnaris, flexor carpi radialis, flexor distal profundus, and palmaris longus. These are the 4 muscles for flexed wrist. So flexor carpi radialis. So for flexor carpi, just a minute. So for flexor carpi radialis, so as I have already told you that this is the medial epicondyle. This is the, you can see in the video, this is the medial epicondyle. This is the bicep tendon. The midpoint joining is the line, and 2 finger breadth distal to this one is the point for frontal teres. So this is the frontal teres muscle. Okay.
Yes. Yes.
After doing section of the flexor carpi radialis, you have to put 3 finger breadth distal to the same point. Medial epicondyle, biceps tendon. You put 3 finger breadth distal, and distal point will be your point for flexor carpi radialis. The flexor carpi radialis you have to activate with the flexion and radial deviation of the wrist. So with that activation, you can target this muscle. But this is for anatomy localization. You should remember 3 to 4 finger breadth distal to the line joining the biceps tendon and medial epicondyle. Okay. Dose will be 50 units. And again, before injecting, you have to see what is the posture of the hand, whether it is flexed with radial deviation more or ulnar deviation more. If ulnar deviation more, you have to give to flexor carpi ulnaris. If radial deviation more, you have to go to the FCR. So depending on the which muscle is overactive, we have to target. Not all muscle you have to target. Okay.
Yes.
Coming to the flexor carpi ulnaris. Just a minute. So flexor carpi ulnaris is usually present on the that region. You have to, I'll show you the pictures. something happened. Just wait a minute, the slide stopped. So you can, all of you can do the movement of this one. So this will the flexion, medial deviation. So this is the muscle for flexor carpi ulnaris. So you can go ahead with the volar aspect, 2-finger bend, 1/3 and 2/3. You can medial epicondyle and this started process you can divide into 1/3 and 2/3, and the junction point is the point for flexor carpi ulnar and 2-finger bend volar aspect. You can target this one. Just wait a minute, the slide stopped. Okay, so this is the flexor carpi ulnaris. I have already told you that you have the junction of the third. This is the proximal 1/3 and this is the distal 2/3. The point will be the location for the flexor carpi ulnaris, and you have to go 2-finger finger bend volar to the ulnar aspect. So this will be a point. You'll do the activation movement. Okay, you'll do the activation movement to see the action of the flexor carpi ulnaris. If you don't have any EMG guidance, then you can use your finger to see the movement of the muscle and movement of the needle also you can see. And those will be standard 40 units at 1 to 2 sides. Okay. Then come the flexor digitorum profundus. So can anybody tell what is the role of function of flexor digitorum profundus?
Distal phalangeal joints.
Flexion of distal phalangeal.
Yeah. So it causes flexion of the distal interphalangeal joint. Okay. So this distal interphalangeal joint movement is caused by the flexor digitorum profundus. But to access the muscle, you have to put this position. Patient has to put over the table like this, and you have to put your 4-finger breadth just over olecranon. You have to put a little finger and 4-finger breadth. So where is the point of index finger is the point for flexor digitorum profundus muscle. So it's also as we have 4 digits, the flexor digitorum profundus also have 4 fascias are there. One muscle is divided into 4 fascias. So while putting the injection, you can put the needle here and you can activate by doing the flexion extension of the distal interphalangeal joint. And you can see the either needle movement or you can see the EMG if you are using the EMG guidance. And those will be 20 units of botulinum toxin you can give. If patient have a flexion of the distal interphalangeal joint, you can go ahead with the injection of the flexor digitorum profundus. Okay. Then come the palmaris brevis. So this is the muscle we are not using always. That is usually targeted when patient has this cup like a palm. If cup palm is like this, then you can use palmaris longus. But I don't inject regularly this one. Then a cleansed fist. This is the most common type of thing used to see in the post-hoc facility. The cleansed fist, sometimes palm, thumb in the palm. These are the common things if you're seeing post-hoc facility in the distal part. So flexor digitorum profundus. So I'll show you the how to target the flexor digitorum profundus. In the picture, you can see you have to put your what is this? You can put hold the patient's hand with at wrist and with index finger pointing towards the elbow region, and the point where the index finger is keeping, that is the point for medial to that one is the point for flexor digitorum profundus superficial. So like this in the figure you can see. So you put the hand, the index finger medial to the flexor digitorum superficialis. Like flexor profundus, it is also have 4 fascias for the 4 fingers. So you can inject at a common site or you can inject separately also. And function is flexion at the proximal interphalangeal joint. This flexion of the proximal interphalangeal joint is the for activation process. So you can see this video you see. I am holding the finger. So this is the index finger. Just medial to this is the point for flexor digitorum superficialis. Is the video audible? Video visible to everybody?
Yes, sir.
So now I am doing the activation. This one I am doing the without EMG guidance. You can see I am doing the flexion. There is no movement. Now when I doing the ring finger movement, you can see there is the needle is moving. So that means that your needle is in the fossa for the ring finger, and you can inject there 5 minutes. Okay. The second also you can see. This is the second index finger I am moving. You can see there is movement of the needles. But that suggests the needle is at the correct position. So that way also you can have a proper access to the target muscles. Then thumb in palm, the thumb in palm, different muscles are involved, and most common muscle you have to target is the flexor pollicis longus. This is the muscle. This is thumb in palm. Flexor pollicis longus. The flexor pollicis longus muscle is in the forearm muscle. Okay. The forearm muscle, you have to divide the forearm distal 1/3 and proximal 2/3. And the injection site will be here. Okay, like in the picture. Radial starter process and lateral epicondyle give 1/3 and 2/3, and the junction point is the point for the injection. So that is the muscle, and by activation will be by doing the flexion extension of the thumb to see for any activity, or if you have any EMG guidance, that will be also good. Okay, but be careful because just below this muscle is the radial artery. The most of the time you will erroneously puncture the radial artery during that time. So always be cautious while injecting the flexor pollicis longus. Then extended wrist, the muscles are external carpi radialis longus, external carpi radialis brevis, and external carpi ulnaris. So we have 40 minutes. So if it is cutting, then I will send you another link if it cuts in between. Okay. If you're disconnected, then I will share you another link. So extensor carpi radialis longus, brevis, and external carpi ulnaris. So these are the muscles for extended wrist. So this is the extended wrist. This is not common. Most common you are seeing the flexed wrist position. But if you're getting extended wrist position, then you can give to the muscle of external carpi radialis longus and brevis. This is the muscle. You can target the lateral epicondyle, 2-finger breadth distal to the lateral epicondyle. And this is the point, and you can do the activation by doing the extension of the wrist radially and also medially to see for activation. And dose will be standard 25 to 40 units is sufficient for this extensor group of muscles. Then external carpi ulnaris, you can go ahead one half lateral epicondyle and the straddle process, and the middle point will be the external carpi ulnaris. So it is the half between the lateral epicondyle and straddle process. You can remember this one, or also you can take a picture of this one. Or if you want to follow, then this book reference I have given, Anatomical Guide for Electromyographer by Perotto. You can use that this one for proper localization and localization. That will also be helpful for a electrophysiological like EMG and all. Okay. Then intringing plos hand. This is the classical intringing plos hand you can see, and the muscle dorsal interossei and lumbricals. The dorsal interossei classical you can see in the picture. These are the fast dorsal interossei. You can inject here in each muscle. You can give 5 minutes maybe, or maximum 10 minutes you can give. And all the four dorsal interossei you can inject at this position. The fast dorsal interossei and other interossei also you can give. Then lumbricals already you know, lumbricals in the palm. So the target site is this distal palmar crease. This is a distal palmar crease, and this is the proximal palmar crease. So in between the distal and proximal palmar crease, that is the point for injecting the lumbrical muscle. You can give with each interdigital space you can inject, and for activation process you can do the flexion of the MCP joint to see for activity of the muscle if you're using a EMG guidance. You can give at least 5 to 10 units each muscle, and it can target the patient intringing hand, or sometimes the patient has a severe flexion at the MCP joint also you can give. Then extended GGs, you can give extensor distal communis. So this is the muscle. It is 1/3 and 2/3. You can take a photo also. So it's the 1/3. between the lateral epicondyle and to the striatal process, proximal 1/3 and distal 2/3. This is the muscle, and you can do the activation process. You can do the activation process for injecting that one. You can use the standard dose of 20 to 30 units for the extensor digital commonest muscle. Sometimes some patients have extensor indicis proprius activity also. If only EIP is active, then index finger will be extended. In that case, you can only inject the EIP muscle, which is present 2-finger breadth distal to the wrist crease. You can see the finger movement and see the activity by putting the needle. So this one already I've told you, 2-finger breadth or distal to the distal palmar wrist crease. That's the point for external indicis proprius. So this is the muscle also you can see for EIP, EMG also. If you are doing EMG for MND protocol, as per MND protocol, then also EIP is the common muscle targeted for seeing the any neurogenic potential. So thank you. So these are the muscles of upper limb. I think I have finished all the muscles. If you have any question, then we can discuss.
Thank you. Thank you, sir.
So, the risk of pneumothorax in injecting pectoral is major.
Sorry, you're
Sir,
having echo.
the risk of pneumothorax while injecting pectoral is major.
Sorry, you're not audible. Some echo is happening in the background.
Sir, and the risk of pneumothorax while injecting pectoral is major. Okay.
Sorry, I can't hear. Something is happening. You can put in the chat box. I'm not
No
audible.
audible, sir.
Ashwini, tell me.
Sir, ma'am is asking the risk of pneumothorax while injecting pectoral is major.